Okay, so my topic is basically a discussion of what specimens we should be sending and when and how. So this is a these are the types of tests that you might be using to decide when the patient may require an antibiotic or not. So there are ancillary tests that would suggest a patient might have an infection, but can't identify the infection or guide antibiotic choices. So these are things like the full blood count, the CRP, and the procalcitonin. And then there are the more specific microbiological tests that can tell you which bug is causing the problem and possibly how to treat it. And then there are the scoring tools, which can be used to weigh up the likelihood of infection and the severity of infection, which can then guide decisions to treat with antibiotics, as well as decisions like whether to admit a patient or whether to send the patient home. We only really have time to talk about some of these topics. And so I'll focus on the things that we kind of do in clinical practice on a regular basis and how to get the most out of those tests that we do all the time. So the perfect biomarker would be one with 100% sensitivity. So a positive result would mean that an infection was definitely present and that an antibiotic was absolutely required, and also a test with 100% specificity, so that a negative result meant that there was absolutely no infection and no antibiotic was necessary. But obviously there is no test in medicine that meets those criteria. So these are the kind of tests that have varying degrees of sensitivity and specificity for different kinds of conditions. So the white cell count is a traditional marker of infection that is not without value, but has quite poor specificity for infection in general and for bacterial infection as well. It is usually high in bacterial infection, but can be normal, and it can be elevated in many other conditions like trauma or burns, with the use of corticosteroids, and it may, of course, be normal in immunosuppressed patients. It is more useful if it looks like the bone marrow is pushing out new cells, so if there's a left shift and more than 10% band forms. The CRP, which we use all the time, is a positive acute phase reactant. The synthesis starts at about 6 hours after the onset of inflammation, and it peaks at about 24 to 48 hours. It has a half-life of about 19 hours. It's synthesized mainly in the liver, although it's also expressed in adipose tissue in response to inflammatory mediators. And CRP messenger RNA has been found in multiple other tissues as well. The major inflammatory cytokine which induces CRP synthesis is IL-6, but IL-1 beta and tumor necrosis factor also promote transcription. It binds to phospholipids on all eukaryotic cells, especially those that are necrotic and apoptotic, and that includes human cells. So human cells that are necrotic or dying are going to bind CRP and result in elevation of CRP. Its sensitivity is high, but its specificity is low again. It can be elevated with other conditions like burns, TB, connective tissue disorders. There's no clear cutoff to discriminate infectious from non-infectious causes of an elevated CRP. So there's a general feeling that a CRP of more than 100 may be suggestive of a bacterial infection, but certainly for all of us who have treated COVID recently, very high CRPs are associated with primary viral infection. And so there really isn't a clear cutoff to say that one CRP means a bacterial infection and another does not. It is quite useful, however, for excluding a bacterial infection if it's normal or low. And it is most useful for monitoring a response to therapy. So without doubt, CRP is a reasonably cheap tool that provides some information about the inflammatory state of the patient, but which must always be interpreted in the context of each patient's condition. So what about procalcitonin? So when procalcitonin made its debut several years ago, it seemed like this was the answer to everyone's prayers. We would have a biomarker that would tell you about bacterial infection, and we would never have to guess again. And it hasn't materialized as quite such a magic marker after all. It's a precursor of procalcitonin, which is synthesized largely in the thyroid. Increases in PCT occur in various disease states, which then are not accompanied by increases in procalcitonin. It is stimulated by typical pro-inflammatory cytokines, IL-1 beta, IL-6, and tumor necrosis factor, and also by bacterial products and necrotic cells. It can also be seen increasing in septic shock and cardiogenic shock. The response is usually a little bit more rapid than the CRP. You can see the response in about 5 hours, whereas with CRP, it may increase. You may only start to see an increase between 6 and 8 hours. It's downregulated by interferon gamma in viral infections. So, sorry, we're having a little technical problem here. It's downregulated by interferon gamma in viral infections. So it's usually low in viral infections. And again, our COVID experience has taught us that the PCT did not, in that condition, usually go up with COVID. So a little bit more about PCT. The SAP study was a PCT-guided antibiotic cessation strategy study. It was a study looking to see if a PCT-guided cessation strategy in ICU patients was able to reduce antibiotic consumption and duration, and whether it was safe. So the study was able to determine that it did moderately reduce consumption and it was safe, but it also showed an unexpected finding, which was that there was a mortality benefit in the PCT-guided strategy group. So those patients who received shorter durations of antibiotics actually did a little bit better. So here you can see the mortality, the Kaplan-Meier group, showing that the PCT-guided group did a little bit better in terms of mortality. This is a slightly more recent meta-analysis, which examined the records of over 4,000 critically ill patients with various pathologies and confirmed the results of the SAPS trial. It was a PCT-guided strategy similar to the SAPS trial that was associated with improved mortality, also a modest reduction in antibiotic use through shorter treatment duration and earlier discontinuation. So you can see that the plot is all on the left-hand side there, which indicates that it was safe. And this is an algorithm which I think reflects the most generalizable approach to how best to use PCT. So this would be regarded in most areas as the correct approach to using a PCT. I think the one thing that may differ here is that we tend to see much higher values than 0.5 when we see sepsis. And I find myself, from a personal point of view, in general, quite unexcited about a level of 0.5 when it comes to a PCT. But I think this includes quite a few useful pieces of advice anyway, which I've underlined. The one is to keep an eye on the trend of the PCT. If it's coming down and has come down by more than 80%, then think seriously about stopping the antibiotics. It has suggested that the patient has responded to treatment. And I think if your PCT starts out very, very high, an 80% drop is what you're looking for, not necessarily a drop to less than 0.5. Number two is that the PCT on its own should not be used to start or escalate treatment. As with any biomarker, it should be used in conjunction with a clinical picture and should only be requested when there is a clinical suspicion of an infection, and more specifically, even a bacterial infection. So let's talk a little bit about specific microbiological tests. And I will credit Tricia as well here. I've combined a couple of our talks that we give on our antimicrobial stewardship course, and some of this comes from Tricia, so thanks very much. So first things first, it's essential to understand that when you're sending any specimen to the laboratory and hoping for a usable result, is that how and when you collect the specimen matters. If you send junk to the lab, the result you will get will be junk. An appropriate good quality sample is a prerequisite for obtaining useful microbiological tests results. So it's essential, it's ideal to collect the specimens before the antibiotic is given. So there are some reasonable exceptions, obviously. For example, a patient with a suspected bacterial meningitis who presents to a local clinic. The delay between presenting at the clinic and receiving investigations and treatment at the hospital may be long enough to warrant giving a patient a dose of antibiotic before the lumbar puncture can be done in order to prevent adverse outcomes. However, in most circumstances, there is time to take the appropriate microbiological specimens before the antibiotic needs to be given, because it only takes 10 or 15 minutes to get those samples, and you do have enough time to do that before the antibiotic is given. It's always a good idea to collect from the site of the suspected infection. This means that you have to do a proper clinical evaluation to decide where the most likely site of infection is in this particular patient. Often what happens is that we respond to an elevated CRP by doing every single test that you can think of. So we fall back on the septic screen and we send all the samples that we can get our hands on, rather than thoughtfully considering which of those samples is most likely to return a useful result. For example, if a patient has a clinical syndrome consistent with a nosocomial pneumonia, it's not sensible to send a urine sample simply because it's part of the so-called septic screen. So what you want to do is you want to look for signs and symptoms that are associated with infection and inflammation, and then target that site for the collection of specimens. What about an aseptic technique? So I can't really overstate the importance of aseptic technique in the collection of specimens. And remember that an aseptic technique is not 2 swipes with a web coal and off you go. For example, taking blood cultures requires that you wash your hands before you start. You use a sterile pack and sterile gloves. You clean the skin properly with chlorhexidine and 70% alcohol solution, which then must be left to dry. You don't feel around for the vein again after you've cleaned the site. Most people will recommend swabbing the top of the culture bottles before inserting the blood, but not changing the needle. And then it's a good idea also to avoid certain sites for blood culture sampling when taking a blood culture. So the femoral vein is not great for blood cultures. Peripheral lines or sites that are just above a peripheral line are not good for blood cultures. And taking multiple sets from the same site. So while a properly aseptic technique is difficult for some samples like urine, it's also important to pay attention to how those samples are collected as well, and to give the correct instructions to limit the degree of contamination. So again, it's not simply, here's the bottle, please go pee in this bottle for me. So there are specific recommendations for collecting urine samples and blood cultures and so on, which must be followed. We can't go through all of that right now, but it's important to perhaps pay attention and look it up and make sure that you are doing it correctly when you are collecting samples. Then you need to think about what the optimal sample type is. You have to actually pay attention to your choice of sample. If you send the best specimen you can lay your hands on, you will get the best result. For example, a pus swab is a poor specimen. It collects very little pus, in fact. It's subject to contamination, and it often doesn't return a useful result. A pus aspirate would be a much better sample, and tissue is a wonderful microbiological specimen, in fact, if you can remember that it should not be sent in formalin. All right, and then what about adequate volume? So the yield from a specimen depends to a large extent as well on how much you actually send. And here, more really is more. The greater the volume, the higher the sensitivity of the culture. So for blood cultures, again in particular, for adults, you need to put 10 to 15 mils in each of the 2 culture bottles, one aerobic and one anaerobic. And for each septic episode that you're investigating, you should send 2 sets of blood cultures from different sites. That's 2 times 2 bottles, which is between 40 to 60 mils of blood. And if you think that that's only about 1% of a person's blood volume, it's much better to take that 1% than to take less, which is a waste of a sample and doesn't return a result. If you are really and truly limited with the volume of blood, you should inoculate a smaller volume into a single blood aerobic culture bottle. rather than split the volume between 2 bottles. And for CSF, the volume matters as well. The laboratory needs at least 1 ml for the culture. And if you're sending it to the microbacterial laboratory, if you're sending it to the TB lab, you're going to need between 5 and 10 mils of CSF, which is optimal for the mycobacterial culture. So even if I say so myself, this is really good advice and something that you should take to heart. Get on the good side of your friendly microbiologist. And one of the best ways to do that is by telling them the whole story. There's a reason there's a space on the NHLS request form for clinical details. As Tricia was saying earlier, the laboratory often doesn't know if this is a community-acquired or a hospital-acquired infection when they get the sample, and very often they get no clinical details whatsoever. But if the microbiologist knows what's wrong with the patient, they will be able to tailor the advice that they give you for treating the patient appropriately. If they have no information about the clinical syndrome, they can only tell you what the organism is and what it's sensitive to, and that might cause problems. They may not be able to give you the exact advice that you need. So for example, the lab has grown a Klebsiella pneumonia sensitive to tigecycline. All these specimens have grown the same organism. The first one is a blood culture specimen in a patient admitted to ICU with Guillain-Barré syndrome 3 weeks ago. This patient is currently ventilated. They've got a central line that's 8 days old, and they have signs of systemic inflammation. Number 2 is a sputum sample from a patient admitted with a diabetic foot with an elevated CRP of 56. The septic screen was done. This patient has no respiratory symptoms. And the third patient, the specimen is intra-abdominal fluid from the 3rd relook in a patient who presented with 4-quadrant contamination from appendicitis. And this patient also has signs of systemic inflammation. So when you see that Klebs pneumonia that's sensitive to tigecycline, it's a nasty looking Klebs CRE. Your automatic response is to something horrible like that is to prescribe tigecycline when you see that result on the computer. But your friendly microbiologist will tell you not all results are created equal. And if you provide them with the right information, they will be able to guide more appropriate antibiotic choices. So this is the advice you are likely to receive is going to be different for each one. Case 1 is a case of bloodstream infection. And I think it would be foolish to say that this patient doesn't deserve treatment for this infection, but tigecycline is not the drug for you here because it doesn't work well in the blood. Case 2, however, is very likely colonization. And this patient doesn't require antibiotics for the chest, so tigecycline would be inappropriate. This is more of an infection control problem than it is an antibiotic problem. And case number 3 is a situation where tigecycline is very likely warranted and would work well. This advice can only be given appropriately if the information is provided to the microbiology lab. So the take-home messages here are: interpret your biomarker results critically in conjunction with the clinical picture. Be thoughtful about your choice of specimen. Remember, junk begets junk. Culture before antibiotics are given. Send enough or even more than enough. Do it cleanly and always communicate with the microbiology team. Thank you.